Welcome, everybody. We'll go ahead and get started. Thank you all for tuning in. My name is David Lamb. I'm director of the Institute for Social Research at the University of Michigan. Glad to have all of you here to join us for this next installment in our ISR Insights speaker series. For those of you unfamiliar with ISR, we have over 300 affiliated faculty who, along with ISR's excellent staff, produce research projects addressing topics such as wealth and inequality, race and racism, politics and public opinion, and a wide range of other topics, including teen drug use, economic behavior, aging, and health. Our faculty are drawn from almost every school and college at the University of Michigan campus, reflecting the true interdisciplinary nature of our work. The goal of this ISR Insights speaker series is to create a forum for disseminating research findings of our ISR faculty. We've had a number of excellent sessions so far, including educational inequalities in the time of COVID, measuring the impact of COVID-19 on the city of Detroit, wealth and the persistence of racial inequality, mental health and well-being among older Americans during the pandemic, and most recently, a fascinating look at the history and insights from the American National Election Study. Recordings of all of these events are posted on the ISR website, isr.umich.edu. We'll also be posting a recording of today's talk, and we'll post information on upcoming talks on the website and on our social media channels, so be sure to check those places out to stay connected. Today, I have the pleasure of introducing our speakers, Dr. Robin Jacob and Dr. Elizabeth Koshman. Robin Jacob is Research Associate Professor at ISR and the School of Education. She's co-director and founder of UM's Youth Policy Lab, which you'll be hearing about. Elizabeth Koshman is Assistant Research Scientist in the Department of Psychiatry at Michigan Medicine and Program Director of TRAILS, Transforming Research into Action to Improve the Lives of Students, which you'll also be hearing about. In this ISR Insights talk, Robin and Elizabeth will discuss data collected as part of a partnership between the Youth Policy Lab, TRAILS, Detroit Public Schools Community District. In 2019, in order to assess student mental health across the district, the study team collected survey data from nearly 3,500 DPSCD teachers, administrators, school staff, almost 11,000 students, and 800 families. A really fascinating study. Today, Robin and Elizabeth will share findings on the prevalence of anxiety, depression, and exposure to traumatic events among students, the degree to which these are associated with school engagement absences and other behaviors, and the challenges staff and district administrators face in providing mental health services to the students. A few housekeeping items. We're providing live captioning of this event. You can view that by turning on the closed captioning feature on your screen. We'll have Q&A at the end of the presentation. The chat feature is disabled, so use the Q&A feature of Zoom. You can send in your questions, and we'll try to go through them at the end of the presentation. So thank you very much for joining us. Enjoy the presentation. I'll turn things over to Robin and Elizabeth. Thanks very much for coming.
Good afternoon, morning, I guess. I was just checking the time. I tend to lose track of it throughout the day here. So good morning, I'm Elizabeth Koshman. Thank you for that introduction and welcome. I'm gonna get us started with our slides this morning, and then really I'm gonna turn over the bulk of today's presentation to Robin Jacob, who will be going through a lot of our data. But I wanted to provide a couple of opening comments just to provide some context about how this collaboration came to be between the Youth Policy Lab, TRAILS, and the Detroit Public Schools Community District, and to offer just a little bit of context about why we were collecting this information and what we hope to do with the data that we've collected through this really comprehensive needs assessment. A few words of gratitude. The TRAILS program, which I will describe very briefly in just a moment, is supported by many, many foundations and through several state and federal grants. This page continues to grow as TRAILS grows, and none of this work would be possible without the support of many stakeholders and partners. And we always like to offer not just an acknowledgement of their support, but really deep gratitude. Many of these partners have had extensive involvement, certainly in the Detroit and Southeast Michigan area, but also across the state of Michigan. And our partners don't offer only funding, although we're deeply indebted to them for the funding support they do offer, but they have also provided lots of wisdom and guidance and consultation throughout the past several years as we've been involved in this work. And it was actually several of the foundations that collaboratively brokered the relationship between Trails, the Youth Policy Lab, and the Detroit District. So lots of gratitude to them all for the ways in which they facilitate and support this work. Some of you may not be familiar with Trails, so I just want to provide an introduction to what Trails is. You can see we're an acronym, Transforming Research into Action to Improve the Lives of Students. Trails is really focused on this question of access, that we know that in clinical settings, there are a host of evidence-based practices for supporting mental health and wellness among both youth and adults, and that those practices are available in select community settings. So certainly, for example, the psychiatry department maintains the outpatient services in our clinic. There are many outpatient centers across campus where kids can come and access high quality evidence-based mental health care. And we also know that in some of our community-based mental health clinics throughout the state, and certainly in Wayne County and in Detroit, there are settings in which kids can access this evidence-based practices for the treatment of depression, anxiety, post-traumatic stress, and other really common mental health conditions. We also know, however, that schools are the most commonly accessed source of mental health support. And often the frontline professionals, social workers, counselors, psychologists, and even classroom teachers are providing many, many hours of mental health support throughout a school calendar year. But often those professionals don't have access to solid, high quality training in evidence-based approaches to supporting student mental health. Most school counselors and social workers complete extensive graduate training, but often those programs prepare professionals for supportive roles, for providing referrals and treatment recommendations, for active listening, for validating student concerns, all of which are deeply important, but it's very difficult for those staff to access training or to arrive on the workplace setting already having acquired training in core fundamental skills that are appropriate for managing depression, anxiety, and PTSD. And those tend to center around cognitive behavioral approaches and mindfulness approaches to management of mental health and wellness. So the Trails model is really designed to help advance the effectiveness of those school staff members through provision of training and resources. And we also know that without post-training implementation support, and Robin, you can go ahead and advance to that next slide, that the impact of any professional development that we offer is going to be really time limited and difficult to sustain. So what's unique about the Trails model is that we do provide introductory didactic training, usually a one-day seminar in core components of CBT and mindfulness. But we also bridge our school professionals whom we're training with post-training implementation support in the form of coaching. Trails maintains a network statewide of clinical community mental health providers whom we've prepared through about a 20 to 30 week training process to serve as Trails coaches. The training process for a coach, let's back up for one moment, is that we provide training to these CMH, typically CMH providers in fundamentals of CBT and mindfulness. Then we assist them through practice of those techniques with clients on their caseload. And then we help them learn through additional training a very comprehensive coaching protocol. And what you see on the screen there is some photos from a day-long training of community mental health providers linked with the Detroit-Wayne Mental Health Authority. Sorry, now it's the Detroit-Wayne Integrated Health Network, who were becoming trained coaches to partner with the Detroit School District. Some of our coaching is being a little bit adapted right now for supporting this virtual environment that schools are in, but it is this coaching element that really sets Trails apart. As we think about our partnership with the Detroit District, Detroit approached some of the local foundations and funders in their community, expressing that the district was really contending with high rates of mental health and behavioral concerns in their students, and the funders in the area, as well as the district, really wanted to think about ways that they could expand and grow their behavioral health system. So we came to the table about 2 years ago to partner with the district, and there were a number of goals of that partnership that were defined from the outset. Robin, you can go ahead to that next slide. There you go. So the first goal was just to establish a collaboration. Anyone that's worked with a large urban district or with Detroit specifically knows that these initial stages of forming a collaborative partnership are really critical to enabling work to flourish and to be successful long-term. Detroit is an incredibly complex district with lots of history, and they are in a turning point in the way that their school district is functioning. They have obviously recently brought in new superintendent and cabinet leadership, and they are overcoming a history of state management, government management of their district. And this seemed like a really optimal moment for them to think about a partnership with some foundations in the area, as well as U of M, to start building out this comprehensive mental health system. Step 2 of this partnership was to complete a really extensive needs assessment district-wide to understand what the strengths of the district were, what resources were already in place, and to think about what the priority areas were for growth and expansion of programs. Step 3 of our partnership, or goal 3, was to utilize data from that needs assessment to provide some recommendations back to the district about programming that would be appropriate and responsive to their identified needs. Then to pilot some of that program components, test them, make revisions to those program elements, and then implement district-wide a set of practices, really leveraging the skill set and the expertise of district staff, rather than relying on Trails or any other external agency or resource to deliver programming within the district. And then of course, along the way, goal 6 is to evaluate everything that we're doing with the district so that they and we are really aware of ways in which this partnership is moving the needle on availability of programming, access to mental health programming, and of course, student outcomes, both spanning social and emotional functioning and academic outcomes. Our partnership with the district, of course, is very much informed by this needs assessment that Robin is going to talk about in greater detail, but also informed by the district's own keen awareness of the fact that the mental health of their students is a massive priority. The district identified in their Blueprint 2020 a whole child commitment, and they are already doing a lot of work spanning these 3 tiers of behavioral health services to their students. Tier 1 being just making sure that as a district, their students and staff and administrators are aware of topics of mental health, that they are promoting help seeking and decreasing stigma associated with mental illness and clinical treatment of mental illnesses. At Tier 2, the district is focused on how do they provide services to students identified as at risk of mental health concerns. And at Tier 3, how do they manage those students at highest risk of serious self-harm or suicide? So in alignment with those tiers, we began our process of really embarking on this comprehensive needs assessment. I'm going to let Robin take it from there, and then I will join at the end to talk about what did we do with this information gleaned from the needs assessment, and where are we going to go in the coming months and years of working with them.
Great, thank you so much, Elizabeth. I see that there are Q&As coming in, and I just wanted to note that we're going to hold those to the end. We'll try to leave 15 minutes at the end for responding to questions. So keep your questions coming and know that we will try to get to all of them at the end of the presentation. And Elizabeth will be monitoring if there are just some clarifying questions. She can respond as we go. So a little over, I think, 2 years ago now, Elizabeth reached out to the Youth Policy Lab to engage us in thinking about evaluation of the Trails program and the DPSCD project, with the goal of launching a really rigorous evaluation that would help shed light on what was working well and what needed to improve to ensure that the goals that DPSCD and the Trails team laid out were going to be met. And as we began our conversation, we realized that it really made sense for us to get involved right from the start and to partner with them to conduct this needs assessment. And the needs assessment had a number of different goals. So the first one was just to get a better picture of what was going on with student mental health in the district and the factors that were related to those mental health concerns so that we understood the context in which Trails would be implementing their services. The second one was really to think about informing the professional development opportunities that would be offered to staff and the types of programming that Trails would be offering to students to match with the needs that staff and students expressed that they had. And then finally, we decided that we needed to collect a set of baseline measures that we could use for evaluating the effectiveness of the program. We are planning a rigorous randomized trial of the program in DPSCD, and we want baseline data to understand where we were when we started. So we really started our work in the winter of 2019, developing the surveys that we'll be presenting today. That was a long process that resulted finally in a complete set of data that we are summarizing a report that came out this summer. And so that's the report that I will be talking about today. We had really large and diverse representation from everyone across the district. We had almost 11,000 students in grades 8 through 12 participate in our surveys. We didn't offer the surveys to younger students for a number of reasons. We hope to capture some more of the middle school students as we move our work forward. But for this study, we looked at students in grades 8 through 12. We had a 64% response rate among those students. We had over 3,500 DPSCD staff, including instructional staff, support staff, health professionals, administrative leaders, as well as teachers respond to that survey. That was a 66% response rate. We surveyed approximately 800 families and also conducted surveys with 42 police officers. So all in all, we had 90% of all the schools in the district represented in these surveys in some way. I want to make a note that particularly among our students, the students who are most vulnerable in the district tend to be absent on a fairly regular basis, may also be less able to access our surveys. And so we think that in some ways we are underrepresenting the level of need within this district, because the students who are most vulnerable are the ones who are probably most likely to have been missing from our data, since these data were administered in the school setting and overseen by the schools. So students who were absent on a regular basis may not have been available to participate. So, you know, we're going to go through the findings. I will just say that the story here is a complex one. The students in DPSCD are like any other students. They are facing academic pressure. They want to do well in school. They want to be successful, but they are also facing a number of obstacles to being successful: poverty, social environmental stressors, systematic racism, and now COVID-19. And there are lots of barriers, as we will see, to seeking care for mental health disorders and for the trauma that those students experience. At the same time, the district is really driven to help. We presented this these findings to the districts a few weeks ago, and I said, our collaboration with the Detroit Public Schools has been like no other collaboration I've ever experienced. They have been on board since day one, have helped us in every way, and are really committed to providing training, resources, and support to their staff. But they need a lot of help and support in doing so. And so what we get and what you'll see is a population that is at risk. They are facing a lot of mental health challenges. Staff that are experiencing burnout and some vicarious trauma, and a diminished ability for students to engage in their academic work. And then we'll talk at the end about how Trails is poised to try to address some of these problems. So a large portion of students across the Detroit Public Schools experience symptoms of both anxiety, depression, suicidal ideation, and many of them have experienced traumatic events in their young lives. We asked students to report on adverse childhood experiences. Those are items that measure abuse, neglect, and household challenges that students have faced over the course of their young lives. Overall, 61% of students reported experiencing at least one ACE over their lifetime, and 19% of them said that they experienced 4 or more. You'll see on the top line of the slide right here that this is the nationally representative sample of adults. Overall, I think 62% of adults have experienced 1 or more ACE, and only 16% have experienced 4 or more. So you'll see that our students, even though they have not yet reached adulthood, are already reporting higher levels of ACEs than their adult counterparts. And just for a point of comparison, 19% versus 16% of our sample represents approximately 1,500 students. So that's a big difference, even though it looks like a relatively small difference in terms of percentages. Furthermore, national representative samples of adolescents and young children tend to put estimates of exposure to ACE around 50%. So our 61% of students is much higher than national averages there. LGBTQ, homeless students really are experiencing very high levels of ACEs. 37% of LGBTQ students report experiencing 4 or more ACEs. 39% of homeless children indicate 4 or more ACEs. And when you dig down into the details of some of these ACE items, you can see that a quarter of students indicated that they saw or heard a household member hurt or threaten one another. 36% have parents who were divorced. 22 said that they often felt unsupported, unloved, and or unprotected. And then we asked another set of questions directly looking at adverse childhood experiences for teens, and found that 33%, a third of the sample, said that they had often seen or heard violence in their neighborhood or their school's neighborhood, and almost a third had experienced harassment or bullying at school. So not surprisingly, given the challenges students face, we also found high rates of both depression and symptoms of anxiety in this sample. Overall, we had 52% of students indicate 62% of students who experienced mild, moderate, or severe depression. 16% of students had severe depression, and similarly, we had 56% of students who had some symptoms of anxiety. Again, we can see differences in a number of areas. Females more than twice as likely to experience severe depression than males. Also more than twice as likely to experience symptoms of anxiety. And again, non-binary, transgender, LGBTQ students also, and homeless students are also experiencing high levels of both depression and anxiety. So these are very concerning findings. Also, not surprisingly, we see that rates of severe depression and severe anxiety are highest among students who reported a history of 4 or more ACEs. Students who report 4 or more ACEs experience moderate to severe depression at more than 3 times the rate of those who reported only 1 or 2 ACEs. Depression is a key predictor of suicidal thoughts, and we found that many students in the Detroit Public Schools Community District experience high levels of suicidal ideation. We asked students over the past 2 weeks, have you ever considered hurting yourself or thought that you would be better off dead? And fully 31% said that they had at least thought about that on several days over the last 2 weeks. And 16% said that they had those thoughts on more than half the days. 8% said that they had those thoughts nearly every day. 23% of students reported having seriously thought about attempting suicide in the past year. So they had made a plan and thought seriously about attempting suicide. Again, there are a variety of factors that place certain students at higher risk for suicide. Gender and gender identity plays a key role, as does sexual orientation, with girls having thoughts of suicide more frequently than boys, transgender, gender non-binary, and also LGBTQ students having much higher rates of suicidal thought overall. So what are the key takeaways? Students in DPSCD are exposed to significant environmental stressors, and they're experiencing high rates of emotional distress. A third of students in grade 8 through 12 have considered suicide. Many of these students who are experiencing mental illness or trauma exposure report lower levels of student engagement across a number of different dimensions. Interestingly, we asked students what were the factors that had the biggest impact on their well-being overall, and their perceptions of the factors that impacted their well-being were very different than what teachers, health professionals, and their families reported. Students reported that the most important thing that was impacting their well-being was academic stress. However, family, health professionals, and teachers indicated that family stress, social pressure, and trauma were the most important factors affecting child well-being. Interestingly, we found that racism and discrimination were not endorsed by very many of the students, teachers, or staff in the schools, and that was not among the highest priorities among the folks that we surveyed. Students with symptoms of depression were more likely to report chronic absenteeism and poorer academic engagement. So when we look at students who had no or minimal depression symptoms, only 9% of them reported having missed 10 or more days of school, which is considered chronically absent, compared to 22% of the students with severe depression symptoms who said that they had missed more than 10 days of school. Similarly, 53% of students with no or minimal depression reported always studying for tests, compared to 37% who said that who had severe depression and reported always studying for tests. But you can see from all of this that students are they're at least moderately engaged in school. Over 80% said that they try to do well on their schoolwork, even when it isn't interesting to them. Over 60% say they set aside time to do homework and study. So these students are really committed to doing well in school and performing well, but they really have a lot of barriers that are facing them as they try to academic interests. Students who reported symptoms of depression or anxiety or 4 or more ACEs were more likely to report having experienced disciplinary problems as well. So you can see here that orange is severe depression, the yellow are 4 or more ACEs, and you can see that students both who experienced severe depression or 4 or more ACEs were more likely to have been reprimanded for not following school rules. They were more likely to have been suspended from school, and they were more likely to have transferred schools for disciplinary reasons. Similar pattern we find for students with 4 or more ACEs. Mental illness and trauma exposure are really highly correlated with interactions with the school disciplinary system. So students in DPSCD who are struggling with emotional distress or experience significant environmental stressors are clearly less engaged in school and more likely to interact with disciplinary systems. As we'll see in the next few slides, a significant number of students with symptoms of anxiety and depression are not accessing any school or community mental health supports. There are a number of barriers that students face when they are trying to access mental health care. A third of the students say that they have not accessed any mental health care because they don't need it or they don't have any symptoms. And then another close to a third say that they prefer to handle the symptoms on their own. But you can also see that embarrassment, shame, stigma play a large role in keeping students from seeking help, as does worry about privacy and not knowing where to go. Interestingly, very few students said that a lack of insurance or the cost of seeking healthcare were key barriers to their seeking mental health care. We asked students to indicate where they were most likely to seek mental health support, and the number one resource that students endorsed were their teachers. 25% of all students said that they have sought out their teachers for support with stress or related mental health concerns. And that just really speaks to the key role that schools play in supporting students in their mental health. A recent study from the Depression Center indicated that 98% of students, when they were asked to indicate where they would go if a friend was having some severe mental health crisis, they said they would seek out help from their school. And so schools really play a key role. You can see, in addition to teachers, school counselors, coaches or activity leaders, and school social workers are also key resources for students. Among community resources, students are most likely to seek out their primary care physician, and then also church or faith-based leaders and a social worker or therapist. Among students who've not received any mental health care, though, 16% reported 4 or more ACEs, and almost 60% reported symptoms of depression. So you can see that there are a large proportion of students who need access to mental health care who are not accessing it. And that's true even among students who said that they don't have any symptoms, don't need any help. 50% of students who said that they don't have symptoms or don't need help had at least mild or moderate symptoms of depression. And so there really is a need for more support for these students and dealing with their mental health needs. We asked administrators to tell us about the things that made it difficult for them to provide school-based mental health care. And there are a number of barriers that administrators are facing. But the most important barriers that they're facing are insufficient staff or personnel, limited time for staff training in mental health care practices, insufficient clinical expertise among staff, and a limited time for mental health services delivery. So these are some of the things that, as part of the Trails project, we're going to try to address. Concerningly, few staff said that their school offers support for depression, anxiety, or PTSD, despite the high levels of all of those things that we observe among students in the district. So only 16% of staff said that there were programs in place to treat depression or anxiety at their school, and only 7 was available. At the same time, the district really needs better systems in place to identify, refer, and care for students with mental health concerns. 56% of administrative leaders said that there is no formal system in place to identify students in need of mental health services. A quarter of them said that they have no formal system to refer students to school-delivered mental health. And then approximately 15% said that there's no system for responding to students who are at risk of suicide. You can also see that when we look at how other staff responded to these questions, there's a big disparity in what staff know about what systems are in place in their schools, with administrators being more likely than anyone else to say that these systems are already in place. And so one of the things that I think will be important as we move forward is ensuring that everybody knows what systems are in place and how to access those systems to help students in need. It's clear that staff are hungry for training and supporting students' mental health. Over 80% of staff said that they want more training on ways to support students. Teachers said that they wanted strategies for incorporating social and emotional mindfulness in their classroom and best practices for supporting students who are affected by trauma or PTSD. Similarly, almost 80% of the health professionals said that they wanted professional development on best practices for supporting students who are affected by depression or anxiety. And so, you know, this is both An optimistic view, staff are clearly hungry for this kind of support, and also underscores how important it is that we get these supports and professional development to the staff in DPSCD. We can also see that staff are really in need of support for their own mental health. Approximately half of all DPSCD staff reported symptoms of burnout. For example, you can see that well over 50% of teachers said that after work, I tend to need more time in the past in order to relax and feel better, that after work, they usually feel worn out and weary, and that during work, they often feel emotionally drained. Teachers and staff with fewer years of experience on the job are more likely than more experienced staff to experience symptoms of burnout. And it's really important that we are able to provide support to these staff, and particularly the young staff who are just starting out in the profession. Most teachers and health professionals said that they were very interested in professional development opportunities that related to their own self-care and coping with burnout and vicarious trauma. So many DPSCD students are not getting their mental health care needs met, either in school or in their community, and yet school staff and administrators overwhelmingly report a need for an interest in training and resources to offer effective mental health supports. So I'm going to turn it back to Elizabeth now, who can talk about the recommendations that we've made to the district about how we're going to proceed given these findings.
Great, thanks, Robin. And I have been looking at the chat, and I see there's a couple of questions about how will this information that we've gathered through the needs assessment benefit students, and what kinds of training do Trails staff have. So I hope to answer some of those as I go, and then of course we'll leave time for questions and discussion after my comments. So if you remember back to the beginning, Robin, can you just advance one slide there for me? Thanks. The district is really focused on this three-tiered model, and that is also how Trails couches our program recommendations in all districts, is through those three tiers. So as we made recommendations back to the district regarding the needs assessment findings, we organized our recommendations along those three tiers. So let's just look at the very bottom there, tier 1. The first recommendation is to implement district-wide social emotional learning in the classroom. For those of you unfamiliar with SEL, there are 5 core competencies endorsed by CASEL, which is sort of the leading authority on social emotional learning in the country. And those are just basic, developmentally appropriate social skills, appropriate decision-making, safe relationship skills, self-care, self-regulation. And the idea of SEL is that it's delivered to students by their classroom teacher, so that it's available, again, at that tier 1 universal level across the whole district. So we're supporting the district now and providing some training and resources to their classroom teachers to enable them to deliver SEL lessons and curriculum in the classroom setting. In response to COVID-19, we are supporting those teachers in implementation of a Trails created. It's our proprietary SEL curriculum that is also grounded in the cognitive behavioral and mindfulness approaches. And it is a curriculum that is able to be delivered virtually. So while no curriculum is ideal in that virtual setting, it is something that can be adapted to the current context. Second recommendation is to provide universal support for student mental health during times of stress. This is a recommendation that comes specifically in response to COVID-19, as well as a recent microscope on the Black Lives Matter movement and the overwhelming amount of media attention that, while enormously critically important, also really brings home the impact of systemic racism and discrimination to students on a daily basis, where they're confronted with a lot of imagery and maybe an expanding awareness of the impact of racism on their own community. Trails developed a 7-session curriculum specifically being responsive to COVID-19, and added additional sections in there specific to the Black Lives Matter movement and issues of racism and discrimination. And we are going to be providing training in that curriculum to about 250 school mental health providers in the Detroit district, so district staff in the coming weeks, and they are planning to push those groups out to their students starting in the fall. And again, those are materials that can be delivered both in person and virtually. Recommendation 3 is to provide training and resources for family and community engagement. DPSCD has an extensive family and community engagement team with staff as well as parent community leaders, and we're providing some training to those individuals in fundamentals of evidence-based practices, and also helping them support families and caregivers in how best to manage their own children's wellness. Recommendation 4 is to provide training for all staff in effective self-care. Robin talked about burnout among staff and just the stress that they are under, as well as vicarious trauma that staff experience by working with a community that is so impacted by environmental stress. So we are recommending self-care training and practices for staff. That's also an event that we anticipate taking place with all staff this fall. So recommendation 5 is to implement programming to improve awareness of mental illnesses among students. That's again that tier 1 level, just to make sure that kids are knowledgeable of mental illnesses and work to try to decrease stigma associated with help seeking. We are delivering an event, mandatory professional development event for about 6,000 DPS all staff and faculty next week. We're really fortunate to be partnering with some collaborators from the School of Public Health who will be talking together with us for that entire district staff about sort of the potential for mislabeling of kids as learning disabled or conduct disordered or attention deficit hyperactivity disordered, when in fact what is observable behavior in those students is a reflection of underlying depression, anxiety, or post-traumatic stress. So we're really looking forward to having that opportunity to bring in some experts from the School of Public Health whose focus of their work and research is really on the intersection of race and racism and the health and wellness of young people. Moving up to tier 2, Trails, as I mentioned at the outset of today's webinar, is really focused on strengthening the muscle of established school staff to make sure that they are equipped to provide evidence-based mental health practices. So at tier 2, recommendation 6 is to establish a comprehensive system to identify, refer, and provide effective care for students with mental health concerns. We are on a call with DPSCD this morning where they were outlining for us their flow map of how do they identify students, and based on the needs that they identify among their students, maybe through a universal screening, maybe through a teacher delivered or classroom-based screening, how do they refer, to whom do they refer, and what services do they provide to those students. Recommendation 7, of course, is to provide training and support to build the muscle of those existing district staff in delivery of effective mental health supports to their students. At tier 3, our goal is really to make sure that there are systems in place to identify students at risk of serious self-harm or suicide. So that's typically that gatekeeper training, Safe Talk and Assist, or very highly regarded programs that help staff learn to recognize signs and symptoms of suicide and to provide appropriate intervention. And we are also working with some collaborators through Michigan Medicine who have expertise in suicide risk management and prevention to try to provide some training, further training to the district, as well as tools and resources to improve utilization of standardized suicide risk screening tools and improve communication with outside sources of higher levels of care. And then finally, our goal is to really make sure that everything that's occurring is built on a foundation of ongoing program evaluation and data collection. To get this needs assessment off the ground, Robin didn't do justice, I think, in her comments to just how much was required in terms of a collaboration between the Youth Policy Lab, Trails, and the district. We have involvement all the way up to the highest levels of the administration and all the way deeply into the instructional staff and their assessment teams and coordinators who manage student access to computers and technology, management of that parent opt-out. Implementation of this needs assessment was a major undertaking, which really required extensive collaboration and involvement from the district. So as we began to tell them that we hope to complete a similar needs assessment every year of this partnership as we move forward, they had a little bit of panic in their voices, but it is something that we're really committed to, both as we implement programs and as we support them to sustainably measure the impact of services that they are providing. Robin and I have recently co-authored several grant proposals to federal sponsors to also rigorously evaluate some of this programming as it goes in through RCTs, and we're really hopeful to get some of that funding so that we can really say definitively the impact of some of this collaborative work with the district on student health and academic outcomes. Just one more comment about next steps. I did see in the chat function some questions about what are we doing immediately in response to COVID. I think I mentioned that we are working on this COVID-19 stress group, as well as self-care for staff, SEL for teachers, work with parents and families, and of course, just understanding and helping the district build a culture and climate that is inclusive for students impacted by mental health concerns. All of that work is launching now and will continue, of course, throughout this academic year. Moving into the future academic years, we really want to make sure that we are strengthening the muscle of those staff to utilize standardized screening tools and measures, to maintain a really comprehensive identification, referral, and service system within the district, and to make sure that they are partnering with those Trails coaches in their communities so that as Trails as an organization and Youth Policy Lab exit our partnership, we leave them in a position in which they're really leveraging local expertise and resources to sustain these practices long term. So I think that's really all that I wanted to comment on here, and I know we want to leave time for comments and discussion and questions. I'm going to turn my attention over to the chat window now, so we can maybe answer some of those questions in our remaining time.
Elizabeth, do you want to, should we go just in order and you can take the ones that are Trails related and I'll take the ones that are data related?
Sure. So I think I answered that first one. What is Trails doing in response to COVID-19? Happy to discuss that more. You can also go on our website, trails2wellness.org. I can pop that in the chat function so people can check out our website, and you can go right to our COVID-19 page. We have many resources, webinars, materials, as well as this multi-session group that can be delivered in person or virtually. Our Trails counselors trauma trained. So Trails counselors is a confusing term. We have Trails staff who provide training to community mental health providers so that those community mental health providers can become coaches partnering with their district. So we have many layers of training upon training, but really the goal is to improve the clinical expertise of school staff. And yes, we do provide training to school staff in recognition of symptoms of trauma. And we also have materials that are responsive to symptoms of PTSD in students. Trails does not market ourselves or promote ourselves as a trauma treatment intervention. However, we certainly know that symptoms of PTSD impact a lot of kids, especially in these densely urban communities. And so we certainly try to incorporate best practices and training for schools and coaches in serving kids who are impacted by trauma. How is the study team engaging DPSCD leadership in this work? Robin, I'm happy to answer that, or you can, whatever you like.
I can start and then you can follow up. So one of the things that I think is unique about this partnership is that this is all being led by DPSCD. This is intervention and research that they want. And part of what the Youth Policy Lab has been committed to doing is only engaging in partnerships where the research questions and the interventions are being driven by our partners on the ground. And that is, really embodied with this partnership. This is something that DPSCD is committed to. It's something that they want to make happen. They realize that these issues are really central for their students. And so, this started with them, and, they engaged Trails, and Trails engaged the Youth Policy Lab. And so, we've been engaged in regular communication with them and consultation with them from day one, from thinking about the design of the needs assessment, asking them what questions they wanted answered on the needs assessment, keeping them up to date on all the factors that, all the findings that we've learned as part of the needs assessment. And Elizabeth, you can speak to, the way you've engaged with the district around the services you're providing.
Yeah, I would say that I've never had an experience working with any district where their leadership was as heavily involved as this one. I actually have on my phone, I text back and forth with Alicia Merriweather, who's the deputy superintendent. They are more committed to this topic than any district I think I've ever worked with. They are deeply invested in identifying the roadmap. Dr. Vitti himself is very regularly involved in our work, aware of our work. We've had in-person meetings with him in which he talks about the critical importance of mental health. I think they are true champions for their student population and their family population. And so none of this would have been even remotely possible. Again, the amount of coordination across teams at the district was really astounding. And none of that would have been possible without their real leadership, not just partnership, but true leadership. I want to move on just for the sake of time to the next question. What follow-up was provided for students reporting suicidal thoughts in the past week? So we learned a lot about Qualtrics and surveying by working with the Youth Policy Lab. And it was really a great synergy, I think, between our two teams. We were able to use smart logic within all of the surveys so that any student that responded to a survey item in a way that flagged a concern for mental health, for trauma exposure, or for suicide risk, immediately had a pop-up item come up on their screen that provided recommendations for maintaining their safety, seeking help, provided a few pointers for managing symptoms, and also linked them to hotlines, local resources, and sources of support. So we definitely tried to be as responsive as possible. The surveys were anonymous, and that was very intentional. The district was not ready to know the name of every student who reported trauma or reported suicide risk. They certainly don't have the capacity to be responsive to individual students at that level. And we at Trails and YPL certainly didn't want to know the names of students who are reporting trauma or abuse or neglect, because that would put us in a really complicated position. So within the context of an anonymous survey, I feel really good about the way that we manage that suicide risk. I hope we've addressed this question: in what ways can or will the study make an impact in the lives of students? We are building a multi-year extensive collaboration with the district that we hope will improve access to effective treatment. So we certainly have hopes. And if Robin's great grant writing gets us a couple of these federal grants, we'll be able to definitively talk about the impact that we're having on students' lives. QPR, somebody asked, there are many gatekeeper suicide intervention programs. QPR is certainly one of them that has great reputation and literature support. Right now, I think that our grant proposals submitted to look at that tier 3 looked at Safe Talk, as well as Sources of Strength, which is a student-focused model. So lots of different programs to choose from. QPR is certainly another great one. There's a question there about how schools can adjust their disciplinary policies in light of the link between mental health and behavioral challenges. That is absolutely the target of the panel presentation that we're doing next week, to talk about substituting suspension and disciplinary action with mental health support. And then Robin, I think, can talk a little bit about our hopes to utilize our findings both from the needs assessment and from future research to influence policy.
Absolutely. You know, there's so much here, and we've only really touched the surface of what these findings can inform us. And so I think one of the things that we're hoping to do is to dig a little deeper into this relationship between disciplinary action and student mental health, and really try to think about ways that both state and federal policy might be adjusted in light of these types of findings. And so we're looking to, you know, put together some policy briefs on these topics, as well as some peer-reviewed publications that can get out into the wider academic world to help inform policy as it moves forward.
Next question, can you say more about community mental health providers and how they get involved? Are they already working in the community and then receive additional training from Trails? Yes, exactly. We tend to work with the community mental health agencies, and certainly Wayne County has the Detroit-Wayne Integrated Health Network that oversees the majority of the behavioral health organizations working in the Detroit area. The training for a Trails coach, who then goes in to partner with the school staff learning these CBT and mindfulness techniques, as I mentioned at the beginning, is pretty extensive. It's a day-long training in core principles of CBT and mindfulness. Then it is about 15 to 20 weeks of application of those skills with a client from that clinician's caseload, together with a one-to-one consultation phase with a Trails staff member. So a CMH provider would identify a client on their caseload with whom they want to practice all the core skills, and then the Trails staff consultant would then partner with that clinician weekly as they practice those skills and apply them to that case. That usually takes about 20 weeks to complete. At the end of that, by invitation only, those clinicians that we feel would make good coaches are invited to another day-long training in the Trails coaching protocol. That teaches them how to observe school staff member skill, how to provide feedback, how to plan for upcoming sessions collaboratively with the school professional, how to evaluate their delivery of those CBT and mindfulness skills. Absolutely, anyone can get involved. If you're a clinician or you're interested in becoming a Trails coach, please get in touch with us, reach out to us. We would love to connect with you. And then thank you for the last comment. We appreciate you being on the webinar today and all your great questions. We hope that I hope that I've answered those questions directed at Trails.
Thanks so much, everybody.
Well, let me jump back in here. That was absolutely fascinating, excellent presentation. Thanks very much to Drs. Robin Jacob and Elizabeth Koshman. Great presentation on a fascinating project that's gone really well and is obviously doing incredibly important work. Great example of collaboration across campus units, ISR and psychiatry in this case, and engagement with the community, which we really like to do. In this case, Detroit school system. And it sounds like it's really been an incredible, very successful collaboration. So good luck on the rest of the project, and we'll look forward to hearing more. Thanks to everyone for joining. We'll have another installment of this ISR Insight series in September. Watch for updates on that. The video from this presentation will be available on the ISR website shortly, along with our previous excellent presentations. So thanks again to our presenters. Thanks to all of you for coming, and everyone, please stay safe. Bye.
Thank you.